students. In this class, we'll try to understand what are the different factors that are going to affect cardiac output. As we know that cardiac output can be given as a stroke volume into heart rate. Therefore, the cardiac output altered by the changes in either of these factors. Stroke volume, it mainly depends on the end diastolic volume, myocardial contractility, and the peripheral resistance. So end diastolic volume, in turn, it depends on the venous return, the amount of blood which is coming back to the right ventricle. So venous return, in turn, it depends on the respiratory pump, cardiac pump, muscle pump, and the blood volume and the venoconstrictor status. And also depends on the atrial pump, ventricular compliance, and the heart rate. Whereas the myocardial contractility depends on mainly the ventricular mass, the autonomic nervous activity, that is sympathetic and parasympathetic, many hormones, chemicals, drugs. Whereas peripheral resistance, it mainly depends on the viscosity and also the autonomic activity. So the factors affecting cardiac output can be depicted like in a following figure. So it depends on the stroke volume and the heart rate. The stroke volume in turn depends on the end diastolic volume, myocardial contractility, and peripheral resistance. Whereas heart rate depends on autonomic nervous system, hormones, and the chemicals. So sometimes the regulation of the cardiac output can be described as a heterometric regulation and homometric regulation. In heterometric regulation, the initial length of the muscle fiber, that is the end diastolic volume, is going to alter. Okay, so that is why it is hetero. Okay, so which is given by the scientist Frank Starling. So that is why it is called as Frank Starling's law. Okay, so it can also be called as the preload. Okay, so this preload or end diastolic volume mainly affected by, as we know, venous return, the atrial pump activity, ventricular compliance, and heart rate. Okay, so venous return, again, it depends on the multiple factors. Like venous return is mainly affected by the respiratory pump, the thoracic or abdominal pump. Okay, so whenever there is an inspiration, the thoracic cage moves laterally, creates the negative pressure inside, and that sucks the blood during the inspiration. Whereas cardiac pump, it can be a vis a turgo force and vis a fronte force. Vis a turgo force because of the actual cardiac pump which pushes the blood towards the ventricles. In the venous channel, then into the ventricles. Whereas vis a fronte pressure, which is created by the relaxation of the atria or the ventricle, which creates the negative pressure and which tries to suck blood from the peripheral venous channels towards the heart. Okay, whereas muscle pump, the blood in the muscle is squeezed because of the muscular contraction, skeletal muscular contraction. And in the veins also we have channels, we have walls which helps in the unilateral direction flow of the blood in these venous channels. Okay, so that's how whenever there is a contraction of the muscle, the blood always moves from periphery towards the heart. Okay, and obviously the venous return depends on the blood volume. Okay, so which in turn depends on the mean systemic filling pressure. It is the pressure exerted by the blood. So when there is no cardiac activity, when the cardiac activity stands still, the amount of pressure exerted by the blood volume over the vessels is called as mean systemic pressure. So normally it is around 7 mm of Hg. Okay, and obviously if the blood volume increases, the mean systemic filling pressure is going to increase. Okay, and sympathetic activity is going to cause vasoconstriction, and especially the uh, venular constriction, venoconstriction, so that increases the venous return. So atrial pump activity also, it is going to increase the venous return. Sympathetic activity increases the venous return, whereas parasympathetic decreases the venous return. And of course, ventricular compliance, it is the elasticity of the ventricle. Okay, so if the ventricle is more elastic, it is able to stretch more and it can accommodate more amount of blood. Okay, so end-diastolic volume is going to increase and stroke volume is going to increase according to that. Okay, it is affected in some pathological conditions like fibrosis. Okay, so because of hypertension, there will be over thickness of the muscle fiber where compliance get affected. So there also the cardiac output is reduced. So pericardial effusion, where the fluid accumulates around the heart and it is going to resist the muscular contraction. Okay, and obviously the heart rate, the EDV is inversely proportional to the heart rate. Okay, so if after a certain level of heart rate, if the heart rate increases, the end diastolic volume is going to reduce. That one should remember. So myocardial contractility. Okay, so it depends on many inotropic factors which are going to increase the contractility of the muscle, and this type of, this is the method by which myocardial contractility increases and it increases the cardiac output. So that regulation is called as homometric regulation. Okay. So there are many external factors which are going to increase the myocardial contractility and the cardiac output. Okay, so first thing is ventricular muscle mass. Okay, so it depends on the muscular myocardial contractility, depends on the ventricular mass. Okay, so then autonomic influence, whereas sympathetic increases the myocardial contractility, parasympathetic reduces the myocardial contractility. Then hormonal factors like catecholamine mainly acts through beta-1 receptor, increases the myocardial contractility. The parasympathetic, it is going to reduce the myocardial contractility. Insulin is going to reduce the myocardial contractility. Thyroxine is going to increase the myocardial contractility, whereas glucagon increases the myocardial contractility. So when some of the cardiotonic drug fails, so at the end, glucagon is used to improve the myocardial contractility. Okay. So then other factors like chemicals, the status of partial pressure of carbon dioxide, oxygen, and H plus ions. Okay, so it is going to reduce the myocardial contractility, especially the hypoxia, hypercapnia, and acidosis. Okay, so drugs like digitalis, which are given to improve the myocardial contractility. So they are going to, increase the calcium availability in the sarcoplasm, and they, increase the myocardial contractility. Okay, so this is called as homometric regulation, where the cardiac output is increased because of increase in the myocardial contractility. The third factor, the peripheral resistance, which is also called as afterload. Okay, so it is the load when put on the ventricular muscle when the muscle is contracting. Okay, and obviously this is going to act against the contraction. Okay, so if there is an increased afterload, obviously the contractility is reduced and the cardiac output will be reduced. Okay, so peripheral resistance mainly depends on two factors: diameter of the blood vessel. Okay, so if the diameter of the blood vessel is less, the peripheral resistance is less, and if the diameter of the vessel is less, the afterload is more or peripheral resistance is more. Okay, and it also depends on the viscosity. If viscosity increases, it is going to increase the peripheral resistance and increases the load on the heart. Okay, so it is inversely proportional. So then heart-lung preparation is experiment done in a dog to mainly study the effect of preload and afterload. Okay, so here anesthetized dog is used, and the heart is connected to the tubings, and they will study the effect of load on the cardiac muscle fibers. Okay. So the cardiac output, the right and left ventricle must pump out exactly equal quantity of blood per each minute. Okay, and the heart is a demand pump, and the sole regulator of the cardiac uh, output is a tissue oxygen demand. Okay, so if the tissue oxygen demand increases, then the cardiac output is going to increase to that particular tissue, mainly by causing vasodilatation. Okay, so regulation of the cardiac output can also be discussed as intrinsic regulation or extrinsic regulation. So intrinsic regulation uh, is autoregulation by the heart itself, works on Frank-Starling's mechanism. Okay, so regulation of cardiac output or stroke volume mainly is done by end diastolic volume. Okay, and also it is by regulation of the heart rate, whereas extrinsic regulation is mainly by the external factors apart from the heart itself. Okay, so it is mainly by regulated by the afterload, that is called as peripheral resistance, some neural influences of autonomic nervous system, and the humoral factors like hormones, catecholamines, thyroids, glucagon, insulin, etc., and the chemicals. Whereas they're going to depress uh, the the cardiac output. Okay. Cardiac functions curve. Okay, so heterometric regulation of the cardiac output can be studied by Frank-Starling curves. Okay, so here you have curves which are drawn against the end diastolic volume versus the cardiac output. As the end diastolic volume increases, the cardiac output is going to increase in this curvilinear fashion. Okay, as you see in the normal graph there. Okay. So the second one is the family of Frank-Starling curves, showing the effect of changes of myocardial contractility on Frank-Starling curve. Okay, so the shift to left occurs when in hyperactive heart in case of sympathetic stimulation with drugs like digitalis. Okay, and shift to right occurs in a hypoactive heart as case of hypoxia, hypercapnia, or acidosis. Okay, so in hyperactive heart, the curve is going to shift to the left side where it is denoted by the blue lines. In hypoactive heart, the normal curve is shifted to the right side. Okay. So regulation of cardiac output during exercise, both the mechanism, extrinsic as well as intrinsic mechanism, they help in improving the cardiac output. During mild to moderate exercise, the cardiac output increases mainly by the sympathetic stimulation, whereas in severe exercise, there is activation of, because of intrinsic activity as well as extrinsic activity, it is going to improve the cardiac output. Okay, so here mainly the venous return increases with the severe exercise, that increases the end diastolic volume, so the cardiac output is increased to many times. Cardiac failure is a condition where the cardiac performance or the cardiac output is less than the venous return. So the blood tries to, it is pooled in the ventricles. Okay, and because of the pooling of the blood in the ventricles, it tries to backflow. Okay, so if the blood pooling occurs in the left ventricle, it goes back to the pulmonary vasculature. If there is a right ventricular failure, the blood starts pooling in the venous channels. Okay, so some of the signs of cardiac failure, there can be cardiomegaly, prolonged circulation time, raised GVP, especially in right ventricular failure, pulmonary congestion occurs in the left ventricular failure, hepatomegaly occurs in the right heart failure, uh, the general edema, the limb edema usually occurs in the right ventricular failure. Dyspnea occurs because mainly the congestion in the lungs because of the failure of the left ventricle. Okay. Okay. So this is all about the cardiac output, the factors that are going to affect the cardiac output in brief. Thank you.